Talking about shoulder passive range of motion examination and the details that need to be done here. So it depends on, obviously, the presentation is what the answer is always, right? First, if they're a very irritable presentation, this is most common when I see it like right after a rotator cuff repair or any type of surgery, and they've had their arm like this, and then you're the first person that's about to move it around. They're wary, especially if you've done the other one to see how that one's moving. You come over here, and like, you about to do that one to here? I'm going to be a lot slower on this one. With this side, so I want to know, can they even get up to 90 degrees? And sometimes they're irritable when they're coming out of it. So I want to come back down before I really test it. So I started off right here. Notice I'm between my body right here and my arms. They're fully supported. And then I'm going to walk it up like this. And I'm watching their eyes the whole time. And then say, I'm like, okay, 90 degrees. I can't go past 90 because it's awkward to be right there. So I get to 90 degrees and I bring it back. If I get down and like, oh, wow, that was rough. Oh boy, this is going to be, I need to be real careful here. They're not going to have a hard end feel. I just need to see what it's able to tolerate. If that was, any problem there, if there's no problem, now I'm going to put their arm on this side of my body. And I'm just going to, bring it up with my arms because they're not as worried. Now I'm going to pin it because now I'm going to be going past 90 degrees. And I like to say slow at end range makes friends, fast at end range makes enemies. And it's one thing to know that, it's another thing to make sure you don't make any mistakes. So if I'm right here and I'm going to be coming, if it takes an extra minute to do all this, that's all right. I'm watching their eyes. If I think that maybe it's going to be irritable, I'll come out of it. If they're still good, then I'll go back further. Notice I'm still holding here. I'm not just holding down here at the wrist. I've got my arm wrapped around it. So their arm is cradled, their wrist is cradled in my elbow. I've got their elbow with this hand. And I'd like to feel with the back of my hand at the scapula. If I'm confident in how this is feeling, but the scapula, as it starts moving, that means there's starting to be some tension. And that may be when it starts to get painful. You want to have an idea where it's going to be painful before they do. You want to just feel that. Now, if it's real irritable and empty end feel, you may not. But it's always about being slow there. And if that one's all right and coming out, and make sure, just because we're good there, don't just bring it back like that. They want to be able to be brought back carefully and slowly. You want them to feel like, man, when he has my arm, it feels great. Not, man, he has my arm, I know it's going to be hurting the rest of the day and I'm going to be a little bit wary. For abduction, you want to make sure your hand is under the elbow and you can walk it out. Just like this. So again, their wrist is cradled in my elbow there, and my hand has their elbow. That way, and then I also just pin it against my waist, against my hip there. As that happens, they feel secure. And abduction, it can be painful quick. I'm not so concerned about the rotation here early on until I get more detail, but I want it to be more supported more than worrying about the rotation there. So that's a real irritable shoulder. And then we have the ones that are not so irritable, they're higher functioning, and we need to get the details of where is it sticky, where is it smooth, where is it painful. So those, I'm going to have my hand right here, but I'm just grabbing at the wrist here, and I'm going to see how it is at the end there. You don't want to just go once and then out of it. How does it feel? What if I just change something? Does it fall? So anytime we have that, we're in flexion and it comes out to the side, it's called a drift. You want to watch that because sometimes I've said, wow, they have no flexion, and then they're telling me they're putting things on shelves. Well, how does that work? Well, because they come out here, they have no problem putting things on shelves out here. They just don't need to do it right there. And so they may be able to have, fully functional flexion. Now, if this is a Major League Baseball pitcher, that's not going to cut it. But for a lot of people, if they can get out to there, some people, they get there and then they drift all the way out to the side. That's not going to cut it functionally. And again, I'm feeling that scapula. So then on abduction, again, I just have the wrist right here, and I'm going to come out here. I can also do it with the palm down, so it's a neutral, so palm down versus thumb up. So, and you want to see if there's a difference there. You want to feel that scapula there. And where can they get to? I also like to do, it's always essential to do external rotation in neutral. This is how we look for adhesive capsulitis. Sometimes the funny ones that we're not sure about, you pin it in here and out to there. If they have that, it's probably a little bit painful right there for them. It is for me. But if they don't get past neutral, if you go to like this with them, and the reason you want to do it passively and not just actively is because a little bit of shoulder abduction can give them a lot more movement. So you pin it to their body and then you externally rotate. If they're right there, it's not adhesive capsulitis unless it is just really early and it hasn't progressed to that yet. But this is pathognomonic for adhesive capsulitis. We want to make sure if it's only stopping right there and they're getting pain, especially in that lateral part of their deltoid, that's very common with adhesive capsulitis. So we're looking at that, and then we're also going to be looking at it in 90-90. Now first, you've already made sure they can get to 90. When I get right here, I like to put it against my leg here, and that way I can support it right there. And you want to see, can it get at least to parallel to the ground while they're in 90, because remember, a little bit of adduction, horizontal adduction, or a little bit of bringing up a little bit of adduction back towards the body can make a big difference. So you just want to make sure that you're watching it carefully. And if they can't get to see where it goes on their head there, and I'll watch right there. You can measure it as well. And or does it go past? And then how does it feel at the end there? Can I give a little bit of overpressure as you see that? And then I'll come and do internal rotation. And it feels really good if you dig their elbow into their coracoid process. Everybody really likes that, right? Where all the nerves are coming out there. So make sure to try to dig your elbow there. But if by chance your patient doesn't like that, just gently put your forearm right there. So that way you can measure internal rotation. Because if I don't have it there and I do that, the scapula can move a lot. You can see that shoulder girdle just going forward there. I don't want that. I want to see how that is, and where's R1, R2, resistance 1, resistance 2. 'Cause sometimes with stiff shoulders, it'll get it really quick, right in there. But then if you go slowly, you can move for several more degrees. And then there is typically we get the most benefit with the stretching. Also, horizontal adduction. So we want to see how that goes. Their elbow should easily get to their nose, if not further. I will pin their shoulder blade. So first you want to see how is it doing just without any pinning. And then I always brace my elbow here on my side. And I'll let their hand rest. Because up here they're having to use their muscle. I say let it rest there. And I can slowly bring it across there. You see right there, his elbow, with it pinned there, his elbow gets to his nose. If they're way out here, and they're barely even getting parallel with their shoulder, then they're perpendicular with the shoulder, then they're going to have limitations in range of motion. So the key with making sure they do a good range of motion exam is that if there's one motion that's off and significantly off, it's affecting other ones, and maybe they just haven't noticed it. Maybe you just haven't picked up on it on the other ones. They're probably noticing some functional limitations. Too often, they'll go to a surgeon. The surgeon will actually do a pretty good job of this. They'll look at motion like, you need better motion. And the physical therapist is like, oh, but it's doing pretty well functionally. No, we need to work on that. Otherwise, it's easy for issues to crop up if we're not doing a good job with the passive range of motion. We want to make sure that we're full in all directions. We didn't do extension. Whatever full is there, you want to see how painful it is. And that is another beneficial way of working into mobility, but looking at the extension is important as well. I just make sure they come off the edge of the table.